Hello, everyone, and welcome. Today, we will be discussing atrial myxoma, the most common primary cardiac tumor. We will cover its key features, clinical presentation, diagnostic approach, and management principles. If you find this helpful, don't forget to like, subscribe, and turn on the notification bell to keep up with medical discussions. Let's get started. Now, let's look a bit closer at atrial myxomas. These tumors are benign, usually globular and pedunculated, meaning they hang by a stalk inside the heart. They can have either a smooth or sometimes a villous surface. Most atrial myxomas are found in the left atrium, okay? Less often in the right and only rarely in both atria or multiple chambers, though that will definitely be an overachieving myxoma. Their clinical features depend mainly on the tumor size and mobility, which is influenced by the length of the stalk. A highly mobile myxoma can actually obstruct the mitral valve orifice, mimicking mitral stenosis, a classic trick question favorite. Now, on the next slide, we will explore how this obstruction affects cardiac hemodynamics and the possible clinical manifestations that result. Here, we're looking at a myxoma on the stalk in the left atrium. Now, depending on its nature, it can be mobile, which allows it to swing into the mitral valve orifice as shown there. This happens during ventricular diastole when the left atrium contracts. If we imagine this line right here as the level of the mitral valve, that means we can say this is the left atria and this is the left ventricle. Then we can appreciate how the tumor can partially or completely block the opening. Now, this explains why atrial myxoma often mimics mitral valve stenosis. Because of this obstruction, blood cannot flow freely from the left atria into the left ventricle. Okay? The result, of course, that is an increased left atrial pressure, which backs up into the pulmonary veins, leading to pulmonary venous congestion and a potential pulmonary edema or even pulmonary hypertension. Below the obstruction, that is this side here, there is a reduced preload because there is less flow coming into the left ventricle, right? That also means there is going to be a reduction in the stroke volume, and as a result of that, there is going to be a decline in the cardiac output. So clinically, this shows up as fatigue on exertion, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, syncope, or even chest pain due to poor coronary perfusion. These are signs of heart failure. Sometimes the obstruction is dynamic, that is, the tumor moves with changes in body position. So, dyspnea may improve when lying flat and worsen when standing upright, which is a curious finding we call platypnea, okay? That is probably when you stand upright, the obstruction becomes worse, and when you lay down, the obstruction gets, relieved, and that can explain that. Additionally, volume status and rhythm changes can also influence how severe the obstruction becomes. And in some cases, the tumor interferes with the mitral valve, okay? And so it leads to a valvular damage and even mitral valve regurgitation over time. So this one mobile little mass can cause surprisingly wide range of hemodynamic effects and symptoms depending on how it decides to swing. So on the other hand, the right atrial myxoma can raise jugular venous pressure by blocking flow through the tricuspid valve, okay? This obstruction leads to a prominent A wave and sometimes irregular JVP fluctuations. You recall this JVP tracing, something like that? I will explain, okay? So we do have atrial contraction. This is going to be closure of the tricuspid valve. This is relaxation, the atrium, and we have filling, that is V, and we have emptying. So if there is atrial myxoma in this compartment and it is blocking the tricuspid valves, then certainly the right atrium will contract more, and so there is going to be more of a prominent A wave, as you can see there. Okay, if the blockage is severe, blood backs up into the liver and abdomen, causing hepatic congestion, ascites, and leg swelling. By the way, you can also watch my video on ascites on this channel. All right, let's keep going. I made this medical mnemonic right here to help you organize your thoughts and remember the key features of atrial myxoma. So A stands for arrhythmia. If the tumor invades deeper into the myocardium, it can disturb electrical activity and cause arrhythmias. B stands for blockage, in other words, flow obstruction. We have already discussed this earlier. The tumor can block the mitral valve orifice, mimicking mitral stenosis. C stands for constitutional symptoms. So patients may present with fever, malaise, anorexia, and weight loss. It is due to the release of cytokines and growth factors, especially vascular endothelial growth factors, which promote angiogenesis. So atrial myxoma can actually cause fever of unknown origin, something to note. And D, defect of mitral valve. So there is going to be some direct impingement of the tumor, and that can damage the mitral valve leaflets, leading to other valvular impairments like mitral valve regurgitation and embolism, which is a key and a dangerous feature. So, venous myxomas can shed emboli to the central nervous system, so this can lead to strokes, transient ischemic attacks, emboli in the viscera or peripheral arteries, increasing mortality risk. Now, here's a quick refresher on the cardiac cycle. So we have S1. This is when the mitral and tricuspid valve close. That's almost simultaneously. We have S2. This occurs when the aortic and pulmonic valve closes. There is actually a physiological split, but for simplicity's sake, we'll keep it like this. Now, the distance between S1 and S2 is systole, and the distance between S2 and the next S1 is diastole. So in atrial myxoma, an interesting finding that may be heard is an early diastolic plop, or otherwise referred to as tumor plop. This is more like, a sound when you drop a solid object into a fluid, okay? This occurs when the mobile myxoma moves and hits the endocardial wall during early diastole. So that is a tumor plop right there. But keep in mind that this sound is not always present, and its occurrence also depends on the size and the mobility of the tumor. So here we're going to take a look at what happens in severe mitral valve stenosis. You may hear certain components. One of them is the opening snap, okay? And this occurs in early diastole. So you can see S2 marks the beginning of diastole, which is actually a high-pitched sound that occurs shortly after S2 as the stiff mitral valve opens, and also because there is more pressure in the left atrium. The second component is a decrescendo diastolic rumble, okay, which is caused by a turbulent blood flow across the narrowed valve. There is another component that is an accentuated presystolic phase, okay, which is actually heard in severe mitral valve stenosis. And you may also hear a loud S1 due to increased atrial contraction trying to force blood through the stenotic valve. Carney syndrome or Carney complex. This is a rare inherited condition that causes multiple types of tumors and distinct skin changes. People with this disorder often develop skin pigmentations. Those are small dark spots on the skin, myxomas in the heart or skin, and tumors in hormone producing glands such as adrenal, thyroid gland, pituitary, or reproductive organs. Now, because these glands can overproduce hormones, symptoms may include cushion-like features or acromegaly, depending on which gland is affected. To evaluate atrial myxoma, several investigations are typically used, with echocardiogram being the first choice. Here's a breakdown. Echocardiogram. This is usually the initial test. It helps assess the size, location, mobility, and extent of obstruction caused by the mass. Transthoracic echocardiography is often sufficient, though transesophageal echocardiography can be more sensitive if needed. Cardiac MRI is also a great alternative, especially when echocardiogram results are unclear. It also provides better tissue assessment and helps evaluate the mass in more detail. Cardiac CT is another option, which is useful in some cases for further imaging, PET scans and coronary angiogram, depending on the clinical situation, may all be utilized. Electrocardiogram sometimes can be useful for assessing any arrhythmias that are related to the mass. And importantly, transvenous biopsy is important for confirming the diagnosis of myxoma. Never forget about a complete blood count, a basic test that can help identify signs of infection or other issues, and also ABGs if complications like hypoxia arise. So, in summary, the typical sequence starts with echocardiogram followed by a more detailed imaging if needed, and sometimes additional tests. Management of atrial myxoma is primarily surgical excision, as this prevents complications like obstruction, embolism, or even heart failure. Prognosis is generally good after surgery. The recurrence rate can vary, so sporadic cases usually have a low recurrence rate, but familial cases, for example, Carney syndrome, may lead to a higher recurrence rate. So, in short, surgery is the main treatment, and the outlook is generally positive, though recurrence can depend on the underlying cause. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.